Good evening, everyone, respected chairpersons, teachers, and friends. I'm going to talk about osteoarthritis of knee. Now, how are we managing our osteoarthritis of knee today? Before knee replacement, for quite a few years, our prescription remains the same in different stages of osteoarthritis, and the prescription is pain relief supplements and maybe some physio. For quite a few years, we do this before it turns into a tricompartmental arthritis, and we advise total knee replacement. And after total knee replacement, patient is happy and doctor is happier. But my question to myself and to my colleagues is this victory or defeat? I believe this is a defeat of orthopedics, and there are many others who believe that it is a defeat of orthopedics, medicine, and science. We rather take pride in changing our tools, from power tools to patient-specific instrumentation to computer navigation to robots, and now humanoid robots with AR, VR, and AI. Now, what I'm thinking is our focus more on machines and less on biology? Should we not be working on stopping the progression of disease? And that is what I'm going to talk about, focus on in this talk. And my call is to save our knees. Let us save our knees. And my talk, this will be mostly science with a flavor of common sense. And the purpose is to stimulate a thought process in my fraternity. We all know osteoarthritis is a painful and disabling disease. It is predicted to be the most common musculoskeletal condition around the world in next 10 to 15 years. Still, we don't have any tool to predict onset or risk of osteoarthritis, and we have no medications approved as disease-modifying agents for osteoarthritis. Now, to look at this, I have divided this talk into few parts. Let's review the present treatment again, and as I said, it is just analgesic, physio, brace, and maybe intra-articular injection. And we keep on waiting for TKR. And this journey can be 5 to 15 years. To make this journey short, we are advising TKR sooner and sooner. Is that the right approach? Now, having done knee replacement for close to 34 years, I have realized there are some downsides of total knee replacement. Number one, it becomes an insensate knee. Though we claim that there is 95% survival of the implant, but up to 25% patients are unhappy with this. And more important, the periprosthetic fractures are becoming a common sight. Such fractures are becoming a common sight with increasing frequency. What is more concerning is that 1 year mortality after a periprosthetic fracture can be up to 45%. So it's a serious condition. Apart now, revision surgeries. 15-20 years back, they were increasing at the rate of 600% in the West, and we are not lagging behind. These surgeries are increasing in incidence with decreasing success rates and very high complication rates. So we need to look at alternatives to knee osteoarthritis. Now, to look at alternatives, we need to deep dive into the disease process. What is the etiology? Is it just the aging, or is it a multifactorial etiology? All aging knees are not same. Actually, it's an interplay of multiple risk factors which predisposes a person to osteoarthritis. These risk factors can be local or can be general. They can be mechanical or they can be biological. Some of these factors are modifiables and others are not modifiable. So all this is well documented in literature. Once we know the factors, what is then the pathogenesis of the knee joint, osteoarthritis? A landmark article published from Stanford School of Medicine about 15 years back changed the total paradigm about pathogenesis of osteoarthritis. It brought out three main findings, three main observations. The first, they said just like rheumatoid arthritis, osteoarthritis is also driven by a very, very low-grade inflammatory process. The second observation was that the inflammatory enzymes and proteins are secreted in less quantity as compared to rheumatoid arthritis. So the tests remain negative. And one very important prediction they made, that if we could target this inflammatory process early on, someday we will be able to prevent osteoarthritis. These findings have been confirmed by studies after studies in last 15 years. Many studies have confirmed and added to the same pathway. Just last year in JBJS, a review article and meta-analysis was published. They again reconfirmed this, that osteoarthritis, like in rheumatoid arthritis, the NLR and PLR ratio is increased. So they have a similar pathological process. So in brief, the pathology is that osteoarthritis is a chronic, low-grade inflammatory, slowly progressive, immune-mediated process. Osteoarthritis knee is a local manifestation of this chronic systemic inflammatory disease. In other words, osteoarthritis and rheumatoid arthritis are two ends of the same spectrum of disease process. Since the markers are not raised in osteoarthritis, the tests remain negative. What are the structures involved? If we think it is just wear and tear of cartilage, no, it's not just that. All the structures in and around the joint have shown to be involved with this inflammatory process. And what is then the cause of pain? Because cartilage has no nerve endings. The cause and source of pain we need to know so that we can target that for our treatment. The cause of pain is inflammation, ischemia, AVN, microfractures, and bone marrow lesions. And the source of pain is again all the tissues in and around the joint. We need to target them as a part of our treatment, as an alternative to knee replacement. So what can be the proposed treatment? Well, the best would be prevention, but as yet, no prevention is available and documented. So the goals of treatment in our osteoarthritis knees are pain relief, deformity correction, improved mobility, and delayed progression of osteoarthritis. How do we achieve this? Since it is a local manifestation of a systemic inflammatory process, our treatment has to be both local and systemic. In last 15 years, a lot of work has been done on local treatment. Variety of agents have been used to control the local inflammation, to help restore the cartilage and to improve the function. Regenerative medicine and orthobiology are established newer branches of medicine and orthopedic disease. This systemic treatment, however, has not evolved that much as yet, but a lot of work is going on, and very soon we will have a well-defined systemic treatment as well. So what is the local treatment? Has two components: biological, to control the inflammation, to help restoration of the cartilage, and mechanical, to restore the malalignment or deformity. There are a variety of drugs which are being used around the world in different phases of clinical trials to control local inflammation, to help to target the cartilage breakdown, to help promote cartilage regeneration. Many of them have shown very good results, but some of them are in routine clinical practice around the world. What are these? At the moment, platelet-rich plasma or the growth factor concentrates and mesenchymal cells from autologous bone marrow and fats. They are being routinely used around the world with good results, and they are approved drugs. Ozone is another molecule which is being increasingly used intra-articular for its anti-inflammatory and regenerative properties. As far as the mechanical part of the treatment, the conservative option remains shoe wedges and the offloader brace. The surgical options are proximal femoral osteotomy, closed wedge osteotomy, and open wedge high tibial osteotomy. We all are doing this. Very recently, couple of years back, a new implant has been approved by FDA, just 2 years back. It is a implantable shock absorber, which is implanted on the medial side like an internal brace, and it helps avoid rubbing of the joint surfaces on the medial side, so helps promote regeneration and restoration. So our philosophy, we offer all this, and whenever we offer intra-articular treatment, like mentioned here, we do thorough knee lavage because that reduces the inflammatory load. And we also do synovectomy if there is synovial hypertrophy, and realignment, we do all the procedure that I mentioned. And recent introduction to our realignment philosophy is needleplasty, which has been popularized by Dr. Jagnesh Patel from Surat. Under local anesthesia, we do pie crusting of the tibial attachment of medial collateral ligament and pes inserius in the anterior 1/3 under local anesthesia, give a valgus thrust, and see how beautifully it restores the medial joint space, and then we maintain it with physiotherapy and braces. Systemic treatment. What has to be the systemic treatment? We target the systemic inflammation, and we control other comorbidities, metabolic imbalance, and osteoporosis, along with lifestyle changes. This was an article published last year in JBJS, where in one group of hypertensive patients who were given non-selective beta blockers, there was 54% reduction in total knee arthroplasty risks. Very important observation, and this really set me thinking. And this also pointed out that these observations can point to new treatments to delay progression of osteoarthritis, some medication. And when I looked into the literature, there are a variety of drugs being used in different stages of clinical trials and in clinical practice in different centers to target systemic inflammation, to target subchondral bone remodeling, to target angiogenesis, and nerve growth inhibitors have also been used. All this is on the premise that osteoarthritis and rheumatoid arthritis have similar underlying disease process. They are both inflammatory diseases. Huge lot of evidence to support this statement. Just a few months back, in August this year, a literature review of all the clinical trials has been published which have targeted systemic inflammation as treatment for osteoarthritis. And they have come out that DMARDs are likely to achieve desirable outcomes. And variety of DMARDs and biologics have been shown to have been proved to be beneficial in osteoarthritis, including low-dose prednisone. There is something called steroid paradox. The low-dose long-term use is safe and effective in osteoarthritis. The lack of positive diagnostic tests, as I said, have usually deprived the patients of appropriate treatment. We know evidence-based that DMARDs can be helpful. What is not known is that the dose, frequency, combination of various drugs, duration of treatment, exact drug regime, and its safety has not yet been worked out and not yet published in literature. A friend of mine, Dr. Arup Mukherjee, some of you might know him, has successfully used and perfected a drug regime for systemic treatment of osteoarthritis over the last 3 decades. I have used it for the last couple of years with very promising results. It has been adopted by hundreds of colleagues around the country. This is basically a low-dose, low-frequency DMARDs with different incubations with their neutralizing medications next day so that there are no side effects. Then there are supportive medications and comorbidity treatment. For example, methotrexate is given 2.5 milligram on alternate day followed by folic acid so that there are no side effects. And there are other drugs mentioned here along with supportive treatment and supplements which are necessary. And it is personalized and customized for each patient. Systemic treatment, our philosophy, we target systemic inflammation with this Mukherjee regime. Our experience is very good, and we have to counsel the patient that like other chronic conditions such as hypertension, diabetes, rheumatoid, hypothyroid, the treatment of osteoarthritis, the systemic treatment has to continue lifelong. The doses can vary depending on the response in each patient. We have to remember that we can't prevent aging, but we can definitely improve quality of life. That is our experience. We have treated about 50 patients over the last 20 months. It's a broad spectrum, effective and safe regime. Some side effects, if occur, are easily manageable. There is some issue about compliance and patient dropout because there are multiple drugs, about 7-8 drugs every day. We are working our way around this, and we should be able to convince the patients about this. So now, if the patient comes to us in different stages of osteoarthritis, our basket of treatment options, both local and systemic, biological and mechanical, has a huge options, and we customize this, fit into the requirement of each patient, and we offer this to each patient as is necessary, and patients are very happy and grateful. And of course, if patient comes at this stage, very late, fixed deformities, bone loss, we know TKR is the only thing they needed. And of course, systemic treatment we can add, and excellent results can be achieved with TKR, provided it is done judiciously. Friends, future, in very soon there will be personalized targeted therapy for different ONE phenotypes. Intra-articular gene therapy has shown very promising results in clinical practice. With the use of certain newer lab tests, machine learning and artificial intelligence, we will be able to predict osteoarthritis in individuals, and so we should be able to prevent it. So my prediction is in next 5 to 10 years, both local and systemic treatment for osteoarthritis knee will be more evolved with the objective to help restoration of cartilage and slow the progress of disease and put it into remission. In next 10 to 15 years, the number of knee replacement surgeries will significantly go down, just like what happened to the rheumatoid arthritis. In rheumatoid arthritis today, only 2.4% patients need knee replacement, whereas in osteoarthritis, more than 50% still need knee replacement. Friends, the summary is that osteoarthritis is not only due to aging, it is not just wear and tear of cartilage. It is local manifestation of a systemic, slowly progressive, immune-mediated inflammatory process. Treatment has to be local and systemic. Local treatment has to be biological and mechanical, and systemic treatment has to be low-dose, low-frequency DMARDs with their mitigation of the side effects and other lifestyle changes and treatment of metabolic imbalance, osteoporosis, and lifestyle changes. Targeted therapy based on knee phenotype, gene therapy, and even prevention should be possible in not too distant future. This can help us save our sensate knees. So friends, my message for you today is, can we prevent ONE? Not yet, maybe in future. Can we slow progression of osteoarthritis? Yes. Can we help cartilage restoration? Yes. Can we put the disease into remission? Yes. Can we postpone knee replacement? Definitely yes, we are doing it in our practice. Can we avoid knee replacement? Should be possible in most cases if they come to us early. Thank you very much for your patient hearing.
Any good questions from the audience? Any doubts? Then we got ready to regeneration. What are the real indications for this therapy?
Sir, the indication, which therapy you're talking, local or systemic? Both, right. You know, it is, the subject is osteoarthritis knee. So if there is pain in the knee joint, there may be early evidence of osteoarthritis grade 1, grade 2, grade 3. We can do local biological treatment, and which we are, in our practice, we are offering platelet-rich plasma and platelet-derived growth factors, which are very recent introduction. We are also giving hyaluronic acid, high molecular weight. PRP, we give 3 doses, hyaluronic acid 1 dose. Before we give this, we do a good lavage of the knee joint, because that reduces the inflammatory load by washing the toxins, and patients are very happy. We have done a lot of audit of our patients. Mechanical realignment, nowadays we have started doing needleplasty. Wonderful results in early varus. Wonderful results, and maintain it with brace and physiotherapy. So that is the local treatment. Now systemic therapy, I'm not giving to every osteoarthritis of the knee, because the first part, the local part, is very successful in many cases. If some patient have got some associated symptoms of inflammation, like enthesiopathies, like hand stiffness in the morning, or like other joint pains, then I add systemic therapy, which is low dose, low frequency DMARDs, along with supportive treatment. And patients are very happy. Many patients have been able to postpone their knee replacement. Some patients who were posted for knee replacement have been able to avoid this, who were bedridden for a long time have started walking again. We are in the process of tabulating all our results, and maybe next conference we should be able to present more data on this.
We heard articular cartilage regeneration. I think one has to think of the simpler methods to make the articular cartilage regenerate. The discussion has been going on for quite some time, though not so loudly, but by subtle methods. Juxta-articular osteotomies increase the blood supply of the articular cartilage. Juxta-articular osteotomy, one of the commonest ones which is being done for the knee joint is HPO, etc. Has anybody observed the thickness of the articular cartilage in these patients, say, followed for 2 to 4 years? Or is there any other method, simpler method than is osteotomy, juxta-articular multiple drilling, which has increased the vertical height of the articular cartilage? I'm really debating.
Sir, thank you very much, sir, for your comments and observations. High tibial osteotomy, as I said in my talk as well, definitely. But we in our practice do when we have to correct a deformity, not only for cartilage regeneration. You know, there are many ways. There are many ways of skinning the cat. High tibial osteotomy, definitely well proven. It restores the joint space. That has been observed and documented. Now, whether it restores the cartilage thickness, The joint space is obviously restored because it restores the cartilage thickness. That is common sense here, inference. But MRI documented studies I'm not aware of, but there would be some. I'm personally not aware of. And as I said, this is definitely a very useful method before going in for TKR.
Dr. Naresh, what concept you have put in and what point you are trying to put up is that they are non-specific inflammatory synovitis and arthritis, which are in the earlier initial stage. And I think this has been each one of us observation that sometimes you find that person is just fine around 55, 40, 45, 50, sudden one joint pain, and you find that signs of a medial compartment always started appearing radiologically and all this.
Yes.
And it's a very short history, and all inflammatory parameters are they are all negative, so you don't get any support. Now, some of these patients I have also observed they were given HCQS, chloroquine for some time, and with all physical measures, so they reverted back to normal life, normal kind of pain-free rejoin. Now, in some of them who have undergone surgery, either HPO or whatever, or either unique compartment, placement, and the tissue was taken. All synovium in all these patients, it shows non-inflammatory synovitis. So it means that the point which you are trying to put in has some merit looking at those. The only thing is that we have to collect that all data to put in as
Thank you very much, Dr. Jain. Thank you very much. Yes, it is all documented. What you have said, that is true. But what is not yet reported in literature, a definite regime. And what I am trying to suggest, which I have not yet found in literature, that, there are advocates of local treatment, PRP, bone marrow, and other things, hyaluronic acid and HTO. But what I'm trying to say that just local treatment is not enough. Systemic treatment is also needed. In fact, we have treated many patients, the 25% of the patients which are not happy with knee replacement. Because there's systemic treatment, there's no systemic treatment. They still have systemic inflammation, and that is still causing pain in the knee in some of them. And in some of them on whom we have put this systemic regime, low drug, low DMARDs, low frequency, they have responded very well. They have improved. TKR, they did not improve. But when we added the systemic treatment in that proven regime, they improved without any side effects. So what I'm trying to say, number one, both local and systemic treatment is needed for osteoarthritis, which has not yet been said anywhere in the world. Number one. Number two, I'm trying to say that systemic treatment, a definite regime we have worked out. We are in the process of publishing it. It is not yet, available in literature. Thank you.
So, really impressed with this talk because the city where I'm practicing, many people they can't afford to take care, and my personal way of treatment is I just always try to avoid the surgeries because the mankind has lived on the earth since so many millions of years without the need for surgery. But these surgeries and everything, these areas are nowadays becoming more and more. So the life is not depending on machines and so if we properly examine and if we properly treat, what I realized is more than 85% of the patients do not need TKR. And everybody straight away they ask one question: if I undergo TKR, will I be alright completely? That is the one common question I come across.
Actually, TKR is like a Chakravyuh, where we can enter but we cannot come back. Once you do TKR, it is an insensate knee. After a few years, you will have a periprosthetic fracture. Then the mortality of periprosthetic very high. Then after a few years, either TKR will loosen or there will be a periprosthetic. If it's loosen, revision surgery. So it's an ongoing thing. I'm not trying to say we don't do TKR. I've been doing for 34 years. I'm becoming more and more judicious in selecting my patients. And when there is fixed deformity, when there is bone loss, we know we can't do anything else. We have to do TKR. And all these surgeries, all the advances in orthopedic science and science in general, we have to adopt them. We cannot refuse to take them, but use them judiciously in right indication and in the right manner. That is my summation.
What I have observed is this much of degeneration in the X-ray may not be correlated with the patient's symptoms.
Yeah, that's all. That is all. That I said, all osteoarthritic knees are not same. There are different phenotypes.
The role of magnet therapy, because in magnet
Yes, I am aware of this, but I have no personal knowledge and experience. Every stage, if it is not responding to, say, 1 month general physiotherapy, general measures, and I will offer. In fact, I've moved on from PRP to platelet-derived growth factor, which is one step ahead. They've become available. They're just recently, last 6 months. So that is relatively simpler, and I do 3 injections. And whenever I do that, in the first time, I do a good knee lavage to reduce the inflammatory load. I add hyaluronic acid. It is well documented that either of them, hyaluronic acid or PRP alone, and if we do both together, it is much more beneficial. First dose, both together, then subsequent 2 more doses of PRP-derived factor after 1 month each. Sorry? First dose, I will give hyaluronic acid and PRP both together after the knee wash. I give separately. I don't mix them, but I give one after the other after, and I make sure that when I give one, I move the knee around, I rotate it so that it distributed everywhere, then I give PRP. I do it under joint block. I give local anesthesia, where I put my arthroscope for knee lavage, and then I dilute 10 cc of 2% xylocaine to make it 40 cc, give it intra-articular, and there's a good block, and I just give a small stab incision to put in an arthroscope, do a good 2 liter knee wash, put 1 suture, and then inject.
no cell
Nothing, never. When there is synovial hypertrophy, that we know preoperatively, then we do arthroscopic synovectomy along with this, if there is synovial hypertrophy. I don't do cartilage debridement and meniscal debridement, only synovectomy, because cartilage debridement and meniscectomy hastens the process of speed of osteoarthritic progression.
Are we not wrong adding more and more demands for the way it is like sometimes even have the top adding indicators and have got the
Yeah, we could say that, in literature, single DMARD has been worked out as of now. But as I said, Dr. Mukherjee, whom I know for more than 3 decades, we have worked together in different countries, and he has perfected a regime over 3 decades, and he has been present. Many hundreds of orthopedic surgeons in our country have already adopted this, and all of them are very happy. And I am doing it for last more 20-22 months. Very happy. Patient counseling is required. Patient compliance sometimes to 7-8 drugs every day is an issue. So we are trying to find a way around that. Local anesthesia. Very good results. Very good results. I showed you the X-ray. That was the patient posted for knee replacement. She was bedridden. Now she is walking without any support. BMAC I'm planning to start both BMAC in subchondral bone and intra-articular. They have very good long-term results, but the cost of its kit is very prohibitive. So I'm studying a bit more, and I'm trying to devise some indigenous method to process that BMAC to get the fluffy layer. And I'm going to start that very soon. Maybe after PRP, if after a few years I will give BMAC.
coming up with some transdermal extrasteroid, which doesn't have.
Nothing, no steroid intra-articular ever I've given into the knee joint. Ever, never. Low-dose steroid, methylprednisolone, less than 5 milligram, well documented in literature that it is very helpful in variety of conditions, in reducing inflammation in osteoarthritis knee without any side effects. Of course, we have to give vitamin D and calcium when we give steroids. And this is called steroid paradox, you know. It is all written in literature and books that low-dose steroid can cure your diabetes, high-dose steroid will worsen your diabetes. Why does it so? Because it reduces the inflammation of pancreatic vessels, low dose, and then improves the pancreatic function and controls the diabetes. So this steroid paradox we have to be aware of. We are just very, very sort of rigidly against any steroid mention, and that we should not be. Sorry? Yes, ozone therapy, hundreds of orthopedic surgeons in our country are doing it intra-articular ozone. I have not yet started it. Maybe in few months I'm going to start it. It is also very useful, very great anti-inflammatory and regenerative properties have been documented and proven, is being used around the world by many orthopedic surgeons as an adjuvant.
Any role of vascular embolization to prevent the
Any role of
vascular embolization people are doing for preventing the progression of the disease?
vascular embolization? No. I don't think there should be any role. It will rather lead to ischemia and enhance the speed of progression of
They
osteoarthritis.
are claiming that
Yeah, there are some studies. I know about them. I'm aware of them, but that is my opinion based on the whole literature, overall literature, and my personal experience and evidence, whatever I've read.
Okay, thank you, sir.
They are called Cisadoas, systemic slow-acting supplements, and they claim for as an anti-inflammatory role. Some studies have shown this, but all those studies are sponsored studies. So it has not yet been accepted. They are studies, but most of all those studies are sponsored studies. You can give them as supplements, there is no harm. I give them as first line to some of my patients. Some of them are happy, some of them don't improve.
Absorption of these drugs,
Which two drugs? Yeah, I said they are Cisadoas and they are not accepted yet because they are all sponsored studies which are available in literature. Yes, steroid means, and which intra-articular steroid? No, big no.
severe pain in the osteoarthritis early.
Give local treatment, as I've said, biological control inflammation by any method. If there is malalignment, correct malalignment by one of the methods with which you are more comfortable.
I think we just conclude this evening session. Thank you so much.
Thank you.
Naresh. Maybe by next year we will come up with more.
Yes, thank you. Thank you.
Thank you.
Thank you.